Hi, everybody. I wanted to start with a topic that's near and dear to my heart. How many people in the room love to cook? True pleasure in life, okay? I love cooking. And I've always, felt like I had a really fairly privileged relationship to food. And I've always wanted the experience that I had in the healthcare system to be a little bit more like cooking and food. I'm not really sure who decided that this part of our health wasn't part of the conversation when you go and experience the healthcare system in a doctor's office or in a hospital. Who decided that doctors and food were two separate things in our culture? It's always seemed to me to be a fairly unfortunate situation. So this is something I made. I wanted to start with something I made. This is stewed chicken with lentil. It's actually my mother's recipe. And part of my privileged relationship to food has to do with the fact that this recipe appeared in the New York Times. My mother's been writing about food for 30 years in the New York Times, and this particular recipe appeared in the pairings column. Anybody ever check out the pairings column? They give you wine and food together. So growing up, this is my mother with my children. To this day, we test recipes on a regular basis in the home, largely at her house. And growing up, I was very lucky because there was always interesting ingredients to work with and things to inspire me that were kind of just coming in the front door, both within our house and in the fridge, that I could cook with, as well as opportunities to go out and experience the best food in the city at the time, in New York, where I grew up. And it's always been, for me, kind of an extraordinary thing to see how my relationship to food and how much it was driven, and health, was driven by taste and by appreciating what tasted good. I was fortunate at this time, as I started to learn about food, it was before calories were invented. So I didn't really have to worry so much about the science and the quantification of everything. I just followed my taste. And one of the other fortunate parts was having contact with some amazing people in the food industry. How many people know who this is? It's a chef named Samuelsson. He's a bit of a rock star now, but back in the day, a superstar beyond my own profile, with all due respect to Mr. Hockenberry there. This is a true superstar in the food industry, and chefs have become superstars. Way beyond, I would argue, the greatest doctor in the world. We're all much more familiar with the greatest chefs now. They're on TV. They delight us. They talk to us about so many aspects beyond cooking. I have an interesting relationship to this particular guy. I got married in 1996 in New York at a restaurant called Aquavit. I don't know if anyone's been there. Swedish restaurant. Very, very good food. Very lucky to get in actually on President's Weekend, on a day they were closed. The only problem was 2 days before my wedding reception, the head chef dropped dead. He was going for a run. I forget what happened. He had a heart attack. And Samuelsson was the sous chef. And so his first night as a head chef happened to be my wedding. So I was pretty proud of that. But it's interesting. If you go to any of his restaurants today, or you spend any time around people like this, what's so amazing is how accessible they are. He's running a huge empire, many restaurants, yet every day he's in those restaurants tasting the food, little bits and pieces, seeing what it looks like as it goes out, checking the buzz in the room, and seeing what comes back on the plate. He has that sense of connection every day to the experience that people are having in his restaurants. How many of you still see patients on a regular basis? All right, but so you have that experience, right? That day-to-day contact. I know in the health system, people in this country at least complain about how doctors might see 20, 30 patients in a day. Imagine 600 meals going out in 3 hours. How do you maintain your feel, your sense of taste, your intimate knowledge of how that food is being experienced? And how do you touch base with your regular customers, whether they are people who are well-known or ordinary people who are coming in? How do you tap into their experience and understand what they're learning, what the pleasure is, what the experience of that food is like? So I wanted to come to and try and take head-on the topic that I was assigned, which is designing ahead of the problem. Not just design, but designing ahead of the problem. And I think about someone like Marcus Samuelsson, and I'm jealous. How does he design and innovate ahead of the curve in food? It's all about taste. It's all stuff he can taste. It's all very immediate. Most of the businesses, most of the clients we work with, that cord was cut decades ago. As their organization scaled, as their industry became an industry, not a cottage industry. And I would argue this might be a bigger cottage industry than healthcare, who knows. But certainly one that I think is using being a cottage industry food to better advantage. But anyway, Marcus can taste it, and a lot of what we do in design, because he has that intimate knowledge of the experience people are having. A lot of what we do in design is to try and bring that connection together for people who have become a bit disconnected from that experience. What is your service in your hospital, your doctor's office, your clinic? What does it taste like? How often do you taste it? How often do you go to other clinics and taste their food? So I want you to keep that in mind, that notion of intimate knowledge. As I go through a little bit, what we've learned is we've tried to bring that connection together and worked across a variety of industries, including healthcare, to strengthen and build that intimate knowledge. And one of the things that we've found, and I'm going to give you a few examples to illustrate it, is you have to think differently about the conversations you're participating in. And you have to understand the way Marcus Samuelsson does, that one of the best things about the meal he provides is the conversation, not the food. So here's a little clinic in rural Zambia. We had the opportunity to partner with UNICEF. We have some UNICEF folks in the room. If you were in our breakout yesterday, you heard more about this project. So this is a shared patient appointment. These are all mothers who've recently had children, and they've walked a considerable distance to get to this clinic. I want to stop for 1 second because I want to make a note here just to set expectations for the rest of the talk. You're going to see a lot of images like this. And the first thing I want to say about them is they're not going to be pretty, beautiful, typical design images. You're going to be seeing images that are a bit about the messy part of design. The second thing is you're not going to see any images of hospitals and doctor's office. You're going to be seeing images mostly about things that are happening outside that sphere. So what's interesting about this? When we think about being ahead of the curve, we don't generally think about impoverished healthcare systems in rural Zambia, I think. Not really what comes to mind at first. So the reason this is interesting is that this clinic doesn't have the staff to do one-on-one appointments with these mothers, so they do it as a group session. And we'd probably think that's a disadvantage. But these girls and their children are now going to be walking several kilometers back from wherever they live, outside the village and outside the clinic. And that's an amazing time. What is the conversation that's happening between them? They didn't just get information one-on-one, they got information as a group. What did they learn? What made sense to them? How do we become part of that conversation? How many people have heard of grassroots soccer? So this is a really interesting initiative that's trying to take reproductive health and make that conversation something that girls can have in a context like this. So they use a metaphor like soccer. And they talk about throwing down the yellow flag if a boy is getting too frisky with you, etc. So they try and take a conversation that's very taboo, not just for the girls, but for their parents. And they try and bring a metaphor to it, to shift the space of conversation and to suddenly make it something that can happen and that you can learn from. It's not just about giving them a set of rules or a set of ideas. It's about creating a space for a conversation to happen. So what's that language that we need to open up the conversation that we're having, to get outside the problems that we know and get to problems that we might be less aware of? This is a woman named Wendy. She lives in Plano, Texas. She manages 3 different health plans, one for her self-employed carpenter husband, one for a child with some major allergies, and her own. And we got to her through a study we were doing with Humana around high deductible health plans and people on limited income. And we were trying to understand, how do you get this person to engage in health decision making? And we brought her into sessions that we ran with some of the executives there. And what we found is that the conversation started with finance. And that until people in the healthcare system could give her a more reliable, a way she could trust to talk about the costs of the system, every other topic was suspect. Every other thing you wanted to get to was suspicious, because that expectation and that concrete understanding of costs was completely elusive. As she talked to different people, it changed every time. So we looked at, again, not sophisticated tools, very simple tools, a tool that might tell her, based on her health profile or the profile of her family, a projected cost for the year that she might be able to budget towards, what it might cost to go to different venues, depending on how she gets that care. Now, this is not exact, and the executives we were talking to were very frustrated that we couldn't get to exact dollars. But for her, this was a lifesaver. So we know that there are simple solutions, and we know that most of those solutions are filled by people. And most of what you can learn and the way you can test those ideas is through people. So this, again, is Zambia as well. This is a community health worker that we worked with over the course of the study. And he's actually a farmer. He's not paid, and he has no healthcare training. Again, would seem to be a disadvantage. But he's very good at weighing children and very good at capturing that information, and he's also very trusted in the community. So how does that become an advantage? How can he have a conversation with a mother about her child that a nurse from outside could never have? This is another community health worker. What's interesting, one of the big insights that came out of this study, so this study was all about vertical transmission of HIV, and it was all about getting diagnoses to these people, community health workers, so they could get them further out into the community. And what was interesting is certain mechanisms that we started to prototype made sense and gave them some of that information. But what was lacking in most cases when we talked to them was the chance to share information with each other. What they wanted wasn't just a diagnosis, a piece of information, and a reminder. They wanted a way to refer to each other and share information with each other as they were learning about the community. So we built, again, UNICEF built with some of building on some of the insights we helped to collect, a simple sharing mechanism, almost like a little Twitter mechanism, for these people to connect to each other for the first time. And an organization that I admire very much is looking at this. What happens when you do this on a much bigger scale? So this is an organization called Switchboard. And they're in the process of getting 25,000 nurses and doctors in Tanzania on a common exchange, in a common directory, so that they can share information across the country. They can message each other without knowing who they are. They don't need each other's numbers. They don't need each other's identities. But they can start to share information on a broader basis. What could you learn if you have this kind of social infrastructure, lightweight infrastructure across an entire country? What could you learn not just about disease, but about changes in behavior and culture? Coming back to the States, here's an example of that same process brought closer to home. That process of finding insights, and in today's world, the ability to turn those insights into meaningful platforms that people can engage with in real time. We were working with a much smaller group of people who all had gone through bariatric surgery. And they're an interesting, sort of extreme case of people who are making dietary changes, and they have some very specific requirements around it. And we went into their homes and we found they had built their own recipe books, back to the topic of food. But they had organized their recipes very differently than you would imagine. A lot of it was based on how close they were to their surgery and their path to rehabilitation, et cetera. A lot of it was based on texture, not just taste, and the sequence in which you ate things. When you have a belly this big, you have to be very careful. If you drink a glass of water before you eat your meal, you're never going to be hungry. It's a very different set of processes. So we created an online platform just to support the research we were doing, so people could share these tips with each other. But what we found is that the platform we were using to generate insights became an asset in and of itself, because it became a place where you could look and understand. They could find each other in ways they had never before, and share information they'd never had a way to share before. And it became a tool that was brought into a pilot research study, looking at how you could improve the adherence rates and reduce complications post-surgery over a 3 to 6 month period. So again, taking a very light layer of infrastructure that connects people, that increases the velocity and the sharing of information, becomes a very powerful way both to support your own knowledge as an organization, but also to continue to grow and extend the benefits and insights and capture new ways that people might want to use this information. So it's not about technology. It's about the way that the technology connect people. And existing systems are critical to that, right? This is a human system. This is a Sangoma in South Africa. Most people in that country, when they have a health issue, go to a traditional healer first. Even the nurses in the clinic that we work in will visit someone like this first. And we're working with an organization that's cross-training them. First organization in the country to get them certified as HIV counselors. So you can go to a clinic now, and you've got a Sangoma, and you've got a traditional member of the health department, and you can choose who to talk to. And it's important because this person can have a very different conversation. So not only does it open up the conversation for that patient, but when you sit down with these guys to figure out what they're learning, to understand how they're communicating what HIV is and isn't, you have a huge opportunity to tap into what are the assumptions and beliefs in that market, to see and look ahead of the problems and understand how people's perspectives are changing. This happens in places like New Jersey, where they've trained barbers to talk about prostate cancer. So I'd ask you, as you think about the types of solutions and services you're working on, who is at the table? What partners do you have at the table? If you're sitting with a bunch of hospital managers and doctors and nurses and even a few patients, you don't have enough people at the table. These are your partners. If you want to get ahead of the problem, you have to look and talk to different people, people you might not consider like a traditional healer. Here's another piece of infrastructure we've overlaid onto for a company called PatientSafe. They wanted to develop a tool to support nurses in their bedside activities, and instead of building something from scratch, we grabbed some iPod Touches and we built a sleeve for them that could do our barcode scanning, et cetera, that could protect them in a hospital setting. But most importantly, they were tools that everybody already knew how to use. So we were able to get them into use within 3 months and learn from them, learn ahead of the problem. Similarly, overlaying on things like mobile services in places like South Africa, we've been able to learn and see and test different messages over time and see how do they resonate with communities. What's the conversion rate and response on HIV messaging depending on the language and depending on the message. So how can you take what you're learning and how can you take the opportunity to identify new problems and test it out on a broad scale, often using infrastructure that you don't own. That could be broad media. This is a partnership we did with MTV around a social platform for health called Tempted. And we were able to engage their on-air personalities to provide coaching through Facebook. And we were able to create a pull on one of their programs called I Used to Be Fat to drive messaging and drive conversations. Last piece I want to touch on is organizations. You want to stay ahead of the problem. It's not just about bringing an organization like Frog in, a partner in, and going deep and starting to see where you can develop that intimate knowledge. It's about how you sustain and nurture that knowledge. We've developed a process called Frog Immersive to try and build up that knowledge as a first-hand experience with our clients. So this is a typical apartment block in a secondary city in China. How many people have been to China? Many people go to China. Most people do not go to places like this. These are huge, vast, sort of exurban apartment blocks. And we had done a study around health in the home and how people organized health products. And we took the team from our client that we were working with, and we conducted all of the ideation and synthesis in an apartment, just like the ones in this building. So we could all see what was that experience like? What did it really feel like to be in that space? What was the immediate experience people have? So how can you take that intimate knowledge and turn it into something that drives organizations? How can you take the team and connect them together and put everyone on the same level who's participating, whether it's in a place like Zambia or China, where we're working with local guides and students to help us identify people to talk to, participants in a study. How do we bring them all together into one room and maintain that dialogue over time? Not just answer the immediate question of the problem we came there to solve, but generate fresh insights. And how do you bring those insights into the larger context of an organization? Through workshops that bring together stakeholders from diverse backgrounds and have them share their experience and look at how they can map solutions across a diverse set of spaces and look for where those crossovers are between health and education and finance. We did a workshop like that with UNICEF, and we developed a framework and a set of tools to help look at how they might use technology and real-time data to improve their ability to stay ahead of problems, to turn around and dramatically transform, using the word of this conference, the way they can react and understand the situations and measure the activities that they're doing. And we've looked large scale at large organizations like Humana. How do you take that kind of insight-generating activity, that ability to pool and gather knowledge from across an organization, and how do you make that part of the way an organization works on a regular basis? So to conclude, to talk about designing ahead of the problem, a couple of key things we would suggest as principles: meeting people where they are and opening up new spaces for collaboration and conversation. focusing on people and not technology, and layering and building on top of existing systems, whether they're human systems or systems that involve technology, but layering on systems that are outside what you directly manage and control. And finally, sustaining the organizational capacity to learn. So building and changing the value people place on those direct experiences, on that intimate knowledge within your organization, because it exists everywhere. One last thought also, look where other people aren't. Thank you.